Namaste. Sawadee krap. Hi, everyone. First of all, I'd like to thank the organizing committee for the opportunity to participate PCSI this year. So this is my talk about PPVI, relevance, prognosis, and long-term implications. So this is my disclosure. So first, I would like to start with the anomalies of the RVOT. I think this is very classic slide showing that majority of the cases will be the native or non-conduit RVOT, which has mostly involving on regurgitation of pulmonary valve rather than stenosis. But about 20% of those patients with RVOT dysfunction or RVOT problems have to deal with the conduit problems, which most of the time having stenosis plus regurgitation. And this is the timeline of the percutaneous pulmonary valve platform. So starting from 22 years ago, the Melody valve implanted, and then just gradually emerging of the different kind of variety of the platforms, including self-expandable up here or balloon expandable down there, like a sapien valve or the My valve, which is just coming 2 years back from India. And also they also have the adaptive device just to present it in order to reduce the size of the RVOT. And then this can be the landing zone or docking part for the balloon expandable valve. In Thailand, we do have 5 options now. The Melody still having the Venus P, the Polestar, and the Sapien, and last but not least, the My valve. I won't go through all of this because it will take a lot of time to explain, but let me show you what I would like to share. In terms of the valve function, especially in the long term, I would start with this very recent publication. I won't go to the previous publication, but just to share with you that this is the latest one made in the US. I mean that recruiting the patient a Melody valve implanted since 2007, and then following up the patient. It's about like 171 patients with RVOT conduits or processes pulmonary valve dysfunction. Just to share with you that the median follow-up time was about 8.4 years, and the 10-year freedom from TPV dysfunction was about 50%, which is quite interesting. I'll show you later on. But in terms of the valve function, as you can see, there is no obvious regurgitation. Well, just mild to moderate, but not severe. And the gradient, most of the cases having, as you can see, steady below 30 millimeter of mercury. And this is what I would like to say that for the Melody valve, after 10 years, half of the patient needs to do something. And this is another publication which is quite very nicely showing that in terms of the long-term outcome from Germany, this is about 240 cases, and 89% of the patient were the conduit RVOT. Majority of the cases would be Melody valve, but about like 16 cases would be was the Sapien valve. Just to share that the mean RVOT gradient remain quite low, less than 20 to 30 millimeter of mercury, even if it's falling up for almost 10 years. And the valve function, as you can see, the PI gradient initially was like this, but even if it's keep falling up for almost 10 years, majority of the case will be trivial or mild regurgitation. So that's why quite fascinating. But this publication is nicely showing that for those particular case with having the gradient over 15 millimeter mercury, or the patient with pre-stented, which representing the high risk of the patient, you can appreciate that the patient with the high risk group has less survival free of intervention. And as you can appreciate that almost 50% of the patient needs to do something after 10 years of age, 10 years down the line. That rings a bell a bit that somehow the valve function, if you keep the gradient above 15, or if you pre-stented with some kind of stent, that may run more risk of the reintervention. And this is the EFS study of the Harmony TPV22 that published about 2 years back. Multi-center, once again, Lee Benson was the first author. That was about 17 cases, very initial outcome, 3 years follow-up of the patient having 2 early explant, and that 2 cases explanted because of the neo-intimal proliferation or ingrowth tissue inside the stent. And interestingly, for those 2 cases, the authors decided to implant another melody valve inside the previously implanted melody valve. So again, this is the first report showing that the valve in self-expandable platform, especially Harmony TPV22, is feasible. Anyhow, just to share that majority of cases just having trivial or mild regurgitation. Of course, some of them has moderate regurgitation after 3 years follow-up, and the gradient also remaining low, I mean less than 30 millimeter mercury after 3 years follow-up. How about the venous P valve? This is the updated C study 3 years outcome of 64 cases who reached 3 years after implantation. And as you can appreciate that the valve function remained intact in most of the cases. And also the mean gradient across the valve is also remain low. As you can see in all the cases, it's less than 15 millimeter mercury. And in terms of the other complication, as you can see, there were 1 patient having endocarditis at 1 year follow-up. At a 1 month follow-up, I mean during 1 month period, the patient, 2 of the patient has ventricular tachycardia. 2 cases had valve thrombosis at 8 days and also 3 years after implantation. Stent fracture occurred in 11 cases, and that was detected during the 6-month follow-up, I mean like routine fluoroscopy in all the cases, which is very nicely showing that there was no any patient having hemodynamic dysfunction after even if the patient has a stent fracture. And in our experience, we did have 16 cases which reached over 6 year follow-up now. You can appreciate that the gradient remain less than 30 in most of the cases, and also PR fraction, PR severity from echo in majority of the cases having trivial to mild PR. And how about arrhythmia? Well, as you can appreciate that different platform has different profile and has different kind of anchoring mechanism. For the balloon expandable, you can appreciate that the sapien valve here is very short, sleek, and very low profile. For the Melody, it's kind of conduit, but there's no flare at all. But for others, for example, like Venus, Harmony, Polestar, PT, Altera, they are all having flare. Even it's less like the Polestar, or even more like the Harmony, Venus, or PT, or sometimes they may have something like a little outward flare with spikes, like the Altera. But as you can see here, that the arrhythmia, especially ventricular arrhythmia, the rate is ranging from 0 up to like 17% or 30% in some particular devices. So again, most of them, even if there was the arrhythmia, but I mean, all of them has resolved and are self-limited. And how about PPVI versus SPVR? So let's start with the meta-analysis done from China. It's about like analyze of the about 4,000 cases from the PubMed and Cochrane library database, about 18 years period, and all of them were Melody and sapien valve. And as you can see here, TPVR has less all-cause mortality, mortality at the longest reported follow-up time point, less incidence, I mean less duration hospital stay, 30-day readmission, and also recurrent PR compared to surgery is less. However, the post-procedure endocarditis looks as if it's higher than surgery, and the odds ratio was 4.6, almost 4.6, and risk of reoperation was about 2.19, 2.2 odds ratio. Again, just to emphasize that there's a pros and cons between the TPVR and SPVR. And this is the made in US study once again in adult hospital in the US since during 2016 and 2017. So they recruited the PPVI cases about 1,000, and also SPVI is about 4,300 or 4,000 cases. For the PPVI, the Melody and sapien XT were the valve implanted. And as you can appreciate that these asterisk bar, I mean here representing statistical significance. Of course, after surgery, the patient may have need blood transfusion, respiratory complication, pre-procedural bleeding, or the pulmonary pacemaker implantation, complete heart block, cardiac arrest, also having a high incidence from surgery, cardiogenic shock, and discharge to nursing facility is different significantly between PPVI and SPVR. And the patient with the STEMI or the PCI somehow is higher in PPVI group. But for this publication, they summarize that they conclude that SPVR has longer length of stay, 5 days in comparison to 1 day for the PPVI. And also they say that the cost of index hospitalization between the SPVR and the PPVI are comparable. Let me show you a bit more on the long-term outcome, especially the reintervention rates after bioprosthetic PVR. So this is a thing that perhaps we need to use as a reference for the PPVI. All the cases here demonstrating from the AIDS center about like 1,300 cases. A majority of case would be tetralogy flow, and as you can appreciate that the bioprocesses the surgeon put was the C. peri mouth, C. magna east, Sorin mitral flow, and the overall 1, 3, 5, and 10 years freedom from reintervention rates was especially at 10 years was about 65%. So again, this is quite similar to what I showed you previously with the transcatheter pulmonary valve implantation platform, where about 50% need reintervention, especially melody. And here you can appreciate that if you can have a look on the age at surgery, for those who need surgery beyond 80 years old, looks as if the reintervention rate at 10 years is even less than those patients who surgically implanted of the bioprocesses before 18 years old. And how about endocarditis? Well, just to share this one, because I think this is quite important publication and also quite recent published. This is again from the US. It's nationwide registry-based analysis of endocarditis risk after PVR, and this study include surgical and also percutaneous PVR that recruit about almost 1,200 cases, and the endocarditis occur in about 4.8% of patients during a follow-up of total about 9,397 patient years. And the homograph implanted risk of endocarditis percentage was about 1.3, and heterograph is about 4.3, and the melody is about 7.5, whilst the sapien and mechanical valves seems to have no endocarditis, and that's probably because the number is were less somehow. And the incidence of endocarditis with the contiguous valve is about 5.4%. As you can appreciate that the graph here representing the numbers of the surgical time that the patient has been treated. And as you can see, the more surgical PVR has been doing, the higher risk of the endocarditis is predicted. And as you can see here, and the below graph, that the contigua and the melody, which is here and there, seems to have the higher risk of endocarditis compared to the heterograph, excluding contigua or the homograph. So this paper eventually conclude that the bovine jugular vein valves have the higher risk of endocarditis, with the risk of IE from the contigua was about like 6.72 HR, and melody valve HR was about 5.49. So if you ask me about prognosis, I would like to say that and conclude that the PPVI has comparable valve longevity in comparison to the surgical pulmonary valvular prosthesis. But you need to keep in mind that you have to try your best to optimize the pressure gradient below 15 millimeters of mercury. And you have to also keep in mind that bovine jugular vein valves somehow having higher risk or more risk of endocarditis. And for ventricular arrhythmia, it looks as if it's less occur and usually self-limited for the PPVI. but it's quite difficult to say completely compared to the surgery because the follow-up period is not long enough. So we need more data on this. And how about the long-term implications? I would like to conclude that there is a positive trend for PPVI over SPVR. Why? Because it's less invasive, and also this PPVI can be a platform for the second, the third, or even more valve-in-valve in the future. And for the last question about the relevance, I would like to say that it depends on where you are. Why? Because the cost is still a major concern for PPVI in many parts of the world, including Thailand. And this is not just a one quick treatment. You need the long-term follow-up. You need a very good dental hygiene. You need a very good patient cooperation, understanding to take the antiplatelet. And again, these are very important. So I'll stop here. Thank you very much indeed of having me, and hope this talk will be useful for your patient and in the future. Thank you.